Okay, and welcome to the Davies Use Case webinar being presented by Rush University on Road Home Program, Center for Veterans and Their Families at Rush. This is a Davies Award-winning use case for the value of health IT. My name is Arnold Simmons, and I'm the Manager of Quality and Patient Safety here at HIMSS. It's my pleasure to moderate this presentation. Core to the HIMSS mission is promoting the use of health information and technology to improve the quality of healthcare delivery. HIMSS promotes and advocates the integration of clinical decision support and best practice guidance, access to clinical data to analyze progress, and information and technology-enabled patient safety tools for all healthcare organizations, clinicians, patients, and community members as vehicles for improving patient outcomes. The HIMSS Nicholas E. Davies Award of Excellence is the pinnacle of the HIMSS Value Recognition Program. The Davies Award recognizes outstanding achievement of organizations from around the world who have utilized health information and technology to improve patient outcomes and value. The Davies Award-winning use cases have been peer-reviewed to validate sustainable, improved patient and business outcomes resulting from health information and technology-enabled care delivery. So it's my pleasure to welcome our speaker for today's webinar, Dr. Philip Held. Dr. Held, you can begin when you're ready, and I'll turn the presentation over to you, and thank you for joining us today.
Hi, my name is Philip Held. I'm the Research Director of the Road Home Program, Center for Veterans and Their Families at Rush. We are part of Rush University Medical Center in Chicago, and the Road Home Program is also a member of the Warrior Care Network, which is a network of 4 different academic medical centers dedicated to the treatment of wounded warriors. In this presentation, I will be talking about Road Home and how Road Home has used its IT infrastructure and data collection methods to really enhance the treatment of post-traumatic stress disorder in its veterans. I will specifically talk about the local problem that we had here, which is post-traumatic stress disorder and the utilization, also known as the underutilization of evidence-based treatments, the assessment of treatment outcomes, and then I will be moving into the design and implementation portion, focusing on our stakeholder meetings that we've had, the development of the post-encounter form, which is our primary tool, development of pre-intake forms, which are secondary tools, and then the utilization of other survey tools such as Qualtrics. I will then move into the utilization of health IT, talk about our EPIC specialty forms and how we're utilizing them, as well as the self-report assessments. And then in the last half of this presentation, I will focus extensively on the value that's been derived as a result of all of these assessment methods. To get started, talking about the local problem being post-traumatic stress disorder, which is a mental health problem that can be the result of the experience of traumatic stress, so situations that occur unexpectedly and impact someone's well-being. Most individuals have likely heard about post-traumatic stress disorder through the news. It's been well documented, although there is some misinformation. What is clear, though, is that post-traumatic stress disorder negatively impacts veterans and civilians' ability to work, maintain relationships, and it also affects parenting and other social relationships. Moreover, it increases the risk for depression, suicide, and substance use disorders, as well as other mental health risks. Post-traumatic stress disorder also has an impact, a negative impact on physical health, and it is paramount that we treat post-traumatic stress disorder to the best of our ability. We also know something about the prevalence of PTSD among returning veterans. Specifically, a recent meta-analysis has shown that approximately 23% of all veterans returning from the current conflicts, Operation Enduring Freedom and Operation Iraqi Freedom, meet the diagnostic criteria for post-traumatic stress disorder. So close to 1/4 of all veterans returning from war meet this diagnosis. We also know that approximately 81% of veterans with post-traumatic stress disorder receive no or another treatment, and only 19% receive what we call evidence-based treatments. These are treatments that have been shown through research to be effective for the treatment of post-traumatic stress disorder, as well as other comorbid disorders. What's even more frightening, and what's the point of the Road Home program, is that veterans with PTSD who complete evidence-based treatments, and this is a sample of outpatient VA clinics, have been shown to complete these evidence-based treatments at a rate of only 39%. So 39% of individuals who start evidence-based treatments in outpatient care are known to not complete these. And there are several reasons why individuals may not be able to complete these treatments or may choose not to complete these treatments. For example, on the patient side, there's a concern about treatment, whether it will work. There's a general mental health treatment stigma, as in I'm weak if I seek mental health care. And sometimes there are also logistical issues, simply I won't be able to make it to treatment, or I have other family or work-related concerns that prevent me from attending therapy on a regular basis. Then we also have the provider side. And for providers, psychologists like myself, there's sometimes the concern that the veterans are not emotionally ready for treatment. Sometimes providers also lack training in these evidence-based treatments, so they may have training in other sorts of psychotherapies, but not those shown to work. Other providers may struggle with the idea of evidence-based treatments, believing that clients may need something more. And then also we know that treatment costs can sometimes be prohibitive, especially as we're talking about longer-term residential or intensive treatments. So what we at the Road Home wanted to do is we wanted to tackle this problem, and we wanted to tackle it by developing a program that can not only be used here at the Road Home program, but that we can disseminate eventually to other sites so that we can overall improve the healthcare for veterans, specifically the mental health care. And our idea was to develop what we call an intensive treatment program that utilizes evidence-based treatments. And for that, we had to identify the most suitable evidence-based treatment. In our case, that was cognitive processing therapy. We then determined the treatment length of what we thought was the most viable length for veterans who would come to an intensive treatment program. We chose for the length to be 3 weeks. And our goal was to, at any point in time, be able to say something about how our veterans are doing. So we wanted to evaluate treatment outcomes as well as also the progress throughout treatment. And lastly, our goal is, to this day, to modify and to continue to improve our treatment program through the use of data. And that brings me to the next point, which is the design and implementation phase of the project. To give you some overview of what the Road Home clinical workflow looks like, any veteran and their family members who are interested in receiving services, all of which are completely free and are able to be obtained by veterans regardless of their service and discharge status, they have to register by calling us, our front desk staff, to get registered into our electronic medical record. Following this initial registration call, veterans then have to go through a clinical intake with a clinical provider such as a psychologist or a social worker. As part of this clinical intake, individuals go through a regular, what we call a biopsychosocial interview that gets at the person's history and the reason for seeking treatment. And veterans also have to complete clinician-administered assessments to determine their diagnostic criteria that they meet, as well as self-report assessments for any other type of mental health problems. Then they get moved into evidence-based treatments that we offer here. And like I mentioned, we have a 3-week intensive outpatient program that we have, but we also offer outpatient care using other evidence-based modalities such as cognitive processing therapy, prolonged exposure, virtual reality therapy, and cognitive behavioral therapy. Once someone has initiated treatment, we use ongoing assessments that are completed by the veteran to know how our veterans are doing. So are they responding to care as we would expect them to or hope for them to? Or is there anything else that we as providers need to do different in order to make care as effective as possible? Eventually, veterans are at a point where they complete treatment, hopefully at a point where they no longer meet the diagnostic criteria for PTSD and are able to re-engage in their everyday lives. And following this, we continue to keep track of them for 3, 6, and 12 months to determine whether the changes that they have made over the course of our programs, whether they last. And as I've written down here, each time point contains important information that can be used to evaluate the program. And so it was our goal to capture all of this data so that we can ultimately improve and continue to improve the effectiveness of our clinical operations, because our ultimate goal is to improve the care for all veterans and their family members, not only those who come through our program, but hopefully also other sites can learn from the work that we've been doing here at the Road Home. So, taking us back to when Road Home started, which was prior to 2015, all that we had at this point in time prior to utilizing health IT was what most people have in the electronic medical records, which includes the progress notes. And as you can see, this is a regular progress note with blanked out information that could potentially identify someone, but all that is contained in this progress note is information about the session, the content of the session, how the patient is doing, as well as also what the next steps are, the plans going forward. And these progress notes are documented by the clinicians following each session. And this is a fairly typical process for psychotherapy. We're required to document all of our encounters. The pros of using progress notes are that we can capture a lot of very detailed information about our patients, which includes demographic, interventions, talk about the type of interventions we use, the intervention length, whether we give any referrals, clinical outcomes. It is very comprehensive. The downside to using progress notes is that the data that is contained in these progress notes is not easily extractable. So anytime we want to use it, we either have to rely on relatively complex machine learning features, or we have to have someone go manually through all of the progress notes to extract all of the data. And while this is very comprehensive, it prevents us from being able to report to our funders what we're doing in a relatively short amount of time. So a lot of extra work is required to get the data that we need if we just relied on progress notes. So what our goal was to develop a system that allowed for comprehensive data collection and enabled us to easily access our data at any point in time. We developed stakeholder meetings with the Road Home program leadership, Road Home program clinicians, research team and data team members, as well as Rush IT, to discuss what the best options are, as well as also what restrictions we have to work with. And what we discovered was that leadership was really keen on making sure that all of our required reports for funders or donors could be met by the data that we capture. We didn't want to leave any opportunities unmet. For Road Home clinicians, their fear was that if we change anything in the system, it would create an additional burden and it would reduce the clinical utility simply because all they would have to do is add additional data. The research team wanted to make sure that we have a system in place that allows us to capture data and draw conclusions relatively immediately, so in real time. And then Rush IT mentioned that it's important to consider the additional time requirements to make sure that the new software that we put into place is actually functional and can be used. So there were several requirements that we then came up with as a result of these stakeholder meetings for the proposed solution. First, we wanted to make sure that whatever we come up with was efficient. We understood that clinicians had very limited time to document their processes, and so whatever we came up with, we wanted to make sure it can be done in 90 seconds or less so that it would add a minimal amount of extra work for clinicians. Next, we wanted to make sure that the data we capture is very comprehensive. So all of the necessary information that we need for funders to better understand our clients, to better understand our program, needed to be able to be captured in one single solution. We also wanted to make sure that the way we capture the data is very accessible. So all of the necessary data needed to be able to be downloaded and worked with. We also needed the data to be in a format that allowed it to be shared with funders and other academic medical centers that we have partnered with to increase collaboration and ensure a continued funding stream. And lastly, we wanted to make sure that the solution we came up with was one, easy to use, but also cost effective. While there are a lot of very comprehensive solutions already out there, we knew that our budget was relatively limited, and also our clinicians, as well as our other staff, didn't have necessarily the time to learn a lot of new, very high-tech tools. So we wanted to keep it as simple as possible and as cheap as possible. And we also did this not just for our clinicians, as well as for our other staff, but also with the idea in mind that if we ever were to transport this program into other settings will have similar limitations in terms of ability to fund and purchase new tools. So talking about the utilization of health IT, what we decided was to use the existing infrastructure through the electronic medical record, specifically through EPIC and its specialty forms. We then also decided that we wanted to include self-report assessments to capture where our veterans are at any point in time during the treatment. So looking at an example of how we captured data via EPIC. EPIC has a feature for specialty forms that we have then redesigned to what we call the post-encounter form. The post-encounter form got its name because the use of the post-encounter form is to be following every encounter that someone has with a client. What we were able to do is we were able to put all of the required information into this post-encounter form. So anything that we needed to know about how severe are my client's symptoms, have they improved since the previous session, what type of intervention am I using, how long have I used this intervention for, how many minutes, did I give any referrals, what's the current treatment status, are they in ongoing treatment, are they about to wrap up? All these types of things are captured in a single post-encounter form that's completed by a clinician following the encounter. What this allowed us is a very cost-effective and easy-to-learn solution. All of our clinicians were already well familiar with EPIC, and adding specialty forms cost us nothing since EPIC was already used by the hospital. It also allowed us to create something, like I mentioned before, that was able to be completed in 90 seconds or less. And in fact, now, for experienced clinicians, this takes no more than 30 seconds to complete following each encounter. So the amount of added work for the clinicians is minimal. Also, every now and then, we have different requirements, different reporting requirements, different questions that we want to answer. And so what the specialty forms in EPIC allow us to do is to modify and to adapt the content. And so as our program grows and we have different needs, we're now able to capture different demographic information. We added additional information about important clinical session content, as well as also what I mentioned earlier, the symptom improvement, which didn't used to be part of the initial post-encounter form that we had developed. So we are able to change it based on our needs at that point in time. Also, post-encounter forms allow us to aggregate the information that we have so that we can easily share it with our partners as well as our funders. And even though the post-encounter forms and specialty forms in EPIC in general seemed like a really good idea, we had common challenges that I believe every other organization would also face as we introduce a new tool. So for example, when we proposed this to our clinicians, there was a lot of hesitation about completing yet another form, checking yet another box in addition to the already heavy workload that they're completing. And so what we wanted to do is we wanted to show clinicians what the addition of these post-encounter forms can do. And so we sat clinicians down, we introduced this form to them and taught them how to use it. And after a relatively short amount of time with a small pilot sample, we were able to feed this information back to the clinicians and say, look, with the addition of these forms, you're able to generate all of this data with minimal additional effort. And once clinicians realized how helpful it was to capture all of this data in such an easily extractable form, that's when we saw this organizational change here at the Road Home, with all clinicians now using EPIC specialty forms for every single encounter. So every time they meet with a clinician, now every time they meet with a client, every clinician is now using the post-encounter forms. In addition to post-encounter forms, we also are using specialty forms in EPIC to capture other diagnostic data. So for example, some of the clinician-administered assessments we have moved into specialty forms, which allows us to, just like with the post-encounter forms, easily capture information about diagnostic assessments, allows us to download this data aggregate it and work with it however we need. And yet at the time when we developed the system, we realized that Epic wasn't in a place where we were able to use it for all of our assessment needs. One of our funders required us to collect data at every single time point that goes beyond clinician-administered data. And so we needed to find a way to collect self-report assessment data at every session, as well as at follow-up time points. And not every client that we see here comes in for therapy. So through the use of telehealth, we needed to have a system in place that allowed us to collect this data remotely as well. And so we landed on a solution with a survey platform called Qualtrics. And what we're able to do through Qualtrics is we were able to use our validated psychological symptom measures, which allowed us to then accurately assess symptoms, and move this into the Qualtrics survey software tool. And the tool, as you can see in the screenshots, is very easy to use. It's a simple survey tool that provides us with immediate scoring that is so that the clinicians can easily interpret it. So while data on the bottom left, such as the PCL5, the PHQ-9, the PHQ-S, may be meaningless to most individuals, clinicians who are familiar with PTSD treatment will know how to interpret these results and will also know the respective cutoff scores. So for example, if I'm a clinician and I'm looking for a cutoff score for the PCL5, I know that a score of equal or greater than 33 indicates that my client is still symptomatic for post-traumatic stress disorder. So our clinicians are easily able to interpret this data. And on the plus side, we as a program are able to use this data to then inform our practices to see, are our clients improving overall? What is it that we can do for our clients? How do we need to change the program to make it more effective, and so forth? And I will talk about this in a little bit more detail later. The other nice thing about using such a survey tool is that we've been able to program it to have suicide screeners built in. And so whenever a veteran flags positive for suicide or potential suicidal ideation, the system automatically informs various individuals in our organization so that they can respond in less than 24 hours via a phone call. And this was important to us given the high risk for suicide in the veteran population. So now moving to the value derived. I already touched on a few of these things, but I wanted to spend a little bit more time on the different areas in which we've derived a lot of value from all of these changes that we've made to the existing electronic medical records, as well as the addition of self-report assessments. So first, I think it's important to understand that we've derived value on many different levels. I'm going to go from top to bottom. So from a clinician perspective, having all of these additional tools allows us to monitor our clients' progress from session to session, as well as also for long-term follow-up. This, in turn, then allows me as a clinician to make adjustments to the treatment that I deliver to my veterans. If I know at every point in time how my veteran is doing, I will have the ability to make changes to further improve their care. At a program level, we're able to do something very similar in that we're able to evaluate our overall program outcomes, and that's especially important for our 3-week intensive outpatient program, because we want to make sure that in these 3 weeks, this very intensive period of treatment, we offer the best possible care for the veterans. And as you will see in a little bit, we can use this data to make changes to the program to further increase its effectiveness. We wouldn't be able to do this if we weren't collecting all the proper data. And then lastly, having all of the data capture in Epic as well as through self-report assessments, we are able to report to our funders how we're doing at any point in time, as well as also to compare our program outcomes to other programs that may offer something similar. So going into more detail, specifically talking about the clinician level. What you see at the top are two graphs, graphed out PTSD symptoms and graphed out depression symptoms, both assessed by validated measures, the PCL5 as well as the PHQ-9. These graphs are very similar to what our clinicians see at every point in time during their care with a veteran. And so seeing these scores and seeing maybe a change in score or maybe even no change in score allows me as a clinician to make a change. So for example, if we look at the PTSD symptoms in the top left, and I see that my veteran scores go from 65 to 65 to 73, that suggests to me that what we're doing is not really working. In fact, their symptoms are increasing rather than decreasing, which is what we would want. So then this allows me to make a change, and as you can see in this case example, the clinician was able to make a change which drastically reduced the individual's PTSD symptoms. Same goes for depression. If we didn't have data from every single session, we wouldn't be able to make these changes, and there's a good chance that the veteran's symptoms would remain rather unchanged over the course of their care. And this is especially important, I mentioned this earlier, for our 3-week intensive program where one day in treatment really matters. We have them only for 15 days of active treatment, and so we want to make sure that every day is as effective as possible. Looking at the value derived at the program level, one of the things that we noticed is that our use of evidence-based treatments has drastically increased. And at the very beginning, we didn't really know how many of our clinicians were using evidence-based treatments. So our goal was to use the post-encounter form that I've introduced to determine how many of our veterans who are seeking care receive an evidence-based treatment. Specifically, we were curious how many of them receive 5 or more evidence-based treatments because that's considered an adequate dose or minimally adequate dose of treatment for PTSD. And so what you can see in this graph is that in 2015, right when we started, very few individuals, only about half of them, received 5 or more sessions of an evidence-based treatment. Once we knew this, we were able to talk to our clinicians and find out the reasons of why this number was relatively low, or at least lower than we had hoped. And a few things that we learned was that clinicians were not trained in all of the evidence-based treatments, and that they had a desire to learn more about evidence-based treatments and improve their skill in those. So in response to this information, we offered clinical trainings, we offered consultation, and as you can see in the following year, the number of individuals who have received 5 or more evidence-based treatment sessions has drastically increased and continues to increase up to the year 2017. What you see then in red on this is the projected number for 2018. The reason why it's currently lower is that many patients are still completing the intake process and have not yet started their evidence-based treatment, but we have no reason to believe that this number would actually go down. In fact, we expect it to increase continuously as we move forward. Thinking about the program level and some of the changes that having data allows us to make, it's really important. So at every cohort for our 3-week intensive program, we assess the outcomes. And by that, I mean we take the average of PTSD symptom improvement based on the PTSD checklist. And as you look at this graph, larger values mean more improvement. And from a clinical perspective, what we're looking for is that a 10-point change, so a 10-point reduction in PTSD symptoms, is what we consider clinically meaningful. What we mean when we say clinically meaningful is that a veteran is likely going to notice a significant improvement in their symptoms or their ability to function. And as you can see, these are all of our 29 cohorts mapped out from the very beginning when we started, cohort 1, all the way up to present day cohort 29. What is very apparent is that there's, 1, a steady increase in outcomes, so we're getting better over time. And then the other thing is that there's important fluctuations between different cohorts. And that's curious for us to know, and we wouldn't have known about these fluctuations had we not systematically assessed this data. Coming back to my first point, the reason why there is a steady change or a steady improvement in outcomes is because we were able to evaluate what we are doing and how things are working. So to give you an idea of what's been happening, at the very beginning, the first 7 cohorts, group cognitive processing therapy, a specific type of therapy for PTSD, was considered our primary driver of the intensive outpatient program. We also offered individual therapy, but what clinicians were doing in individual therapy was largely not monitored. We encouraged them to also use cognitive processing therapy, but there was a lot of flexibility in what clinicians were allowed to do. So we saw that the average change for these first 7 cohorts was near an 8.0 change. We then decided what happens if we put stricter guidelines on individual therapy and really require our individual therapists to deliver cognitive processing therapy for PTSD in individual therapy as well. And that's what we can really see in the second phase from cohorts 8 to cohort 16. As you can see, simply adding individual cognitive processing therapy to the mix and making this a strict requirement almost doubled our outcomes for this period of time. The other thing that's curious is that in cohort 16, as you can see, there was a negative improvement, meaning people on average actually got worse. And so not having this data would have not allowed us to see this. But since we had this data available, and this was a clear outlier from everything, we were also able to connect this with the reason for why this occurred. So in this case, this was a rather difficult cohort with a lot of interpersonal conflict among group members. And because of this interpersonal group conflict, there was very little progress that was able to be made in individual therapy sessions. Looking at this data, we then thought about what else we could do to reduce the amount of interpersonal conflict and to ensure that everybody can move through the program as successfully as possible. And to achieve this, we really shifted the primary driver for treatment from group cognitive processing therapy to individual cognitive processing therapy. And if you look at averages, again, we're able to almost double our outcomes yet again as a result of that. And also, as you can see, the fluctuations are getting better over time. Talking about fluctuations a little bit, what we have seen are clear differences between the 2 cohorts that we have treated in our intensive outpatient program. One type of cohorts consists of military sexual trauma. The other cohort consists of combat trauma. Military sexual trauma simply refers to individuals who have experienced a sexual trauma while in the military. In our combat trauma cohorts, they may have also experienced military sexual trauma, but the primary driver of their PTSD is combat, not military sexual trauma. So when we look at our outcomes and when we look at PTSD diagnosis by week, and we look at the first 18 cohorts, and we compare the military sexual trauma group in gray with the combat trauma group in green, we are able to see that there is a clear difference, especially at the end of week 3 at our final program time point between the 2 groups, with a lot more individuals in the military sexual trauma cohort still meeting the PTSD diagnostic criteria compared to the combat cohorts. And so what we wanted to do is we wanted to figure out, why did this difference exist? And what is it that is driving this distinct difference between cohorts, between different types of traumas, and more importantly, what can we do to make sure that everybody gets the best possible care? So we then evaluated what was going on in our military sexual trauma cohorts, and we noticed that there is a higher incidence of interpersonal conflict. There's also a higher incidence of crises that occur. And when we talked to our front desk staff, it was clear that front desk staff at that point in time was unsure of how to best field these crises. So instead of helping, sometimes it appeared as though they were hurting the resolution of this conflict. So in response to this knowledge, we did a couple of things. One, we added an additional individual therapy hour, an optional one, to the military sexual trauma cohort. The goal of this additional hour was to make sure that individuals had enough time to talk about non-trauma related distress, so that all of the trauma-focused sessions could be used for exactly the trauma-focused work that needed to be done, and that they had a separate place to discuss non-trauma-based distress. The second change we made is we educated all of our staff, front desk to back office, in how to deal with interpersonal conflict, as well as also educated them on military sexual trauma. Following these changes, what we see is a really drastic change in outcomes, to where now, when we look at cohorts 19 all the way up to present day, our outcomes for the military sexual trauma group as well as the combat trauma group are more or less equivalent. Once again, if we did not have this data, we wouldn't have been able to make these changes to our program. And having this data allowed us to really take a close look and combine clinical information with hard data to make changes that ultimately further improved our outcomes for the entire program. And when we look at these data, that only 41%, maybe 42%, meet the diagnostic criteria at the end of our program, that number compares very favorably to other programs that are out there, and it has been suggested that 60 to 72% of treatment completers usually retain their PTSD diagnosis. For us, that number is only 41 or 42%. And so when we look at the program level once more from a different perspective, there is something else that we see, and it's specifically related to our long-term outcomes. What we're interested in is not just helping individuals improve their PTSD severity over the course of the 3 weeks of our program, but we want to make sure that whatever they learn here, they can take home with them, and that the gains that they've made over the course of our treatment program are maintained long-term, up to 12 months, up to 1 year following the completion of care. And what you see here, again, on the y-axis is the symptom severity assessed by the PTSD checklist, or the PCL-5, with larger values representing greater PTSD symptom severity. And then on the x-axis, we have our different time points, one being pre-treatment, post-treatment, 3, 6, and 12 months follow-up. Once again, a 10-point reduction on the PTSD checklist is considered clinically meaningful, as in veterans will likely notice improvements in their symptoms and their ability to function. And what we see is a pretty drastic reduction from pre to post-treatment over the course of only 3 weeks. What we then see is a slight increase from post-treatment to 3 months follow-up, at which point symptoms are then maintained long-term. So this was interesting for us to see, because what we found is that people were doing very well at the end of treatment with what you already saw, most people falling below the diagnostic threshold for PTSD, but then individuals kind of bouncing up a teeny tiny bit. This change up is also not clinically meaningful. Again, it's less than 10 points, but it is noticeable. And one of the reasons that we came up with so far is that it is likely because while individuals are here, they are in a semi-protected environment. But we're not a residential treatment, as in individuals can leave and they don't have to live at the facility. Still, being here is more protected than being home, going back to work, being around family and friends, having to deal with everyday life stressors. And that's how we explain the small increase in symptoms following the completion of our program. Overall, though, what's very important to note is the drop in symptoms from pre-treatment to 3-month follow-up, at which point it stays constant. So individuals notice a very drastic reduction in symptoms that is maintained long-term. And this is promising because most of the time for evidence-based treatments, which are usually delivered once per week over the course of 12 weeks, while these symptoms are maintained, we're able to show that in just 3 weeks, we're able to reduce someone's PTSD and have these scores being maintained long-term. We're also using other technology to really help our veterans with the continued connection to care. Specifically, we're using an online tool called Airtable. We have used Airtable to basically create a large resource list so that veterans who fly to our program from all over the country, including Puerto Rico, including Hawaii, have care once they leave our program. So following the 3 weeks, we want to make sure that they're well connected so that they can maintain all of their gains that they've made while in our program. We have also partnered with NowPow, which is a local Chicago-based organization, to identify other resources that veterans may benefit from in addition to PTSD. So for example, if we select in our NowPow tool that a veteran who is local to Chicago has PTSD, It will also automatically identify resources on mindfulness as well as yoga services that they may benefit from. So when we look at the program level, what we can also do with the help of the health IT that we have incorporated is we can take a look at the overall flow of patients from the initial point at which they express interest in our intensive outpatient program all the way to the completion of the intensive outpatient program. And what we can do is we can identify reasons why individuals were accepted or not accepted into the program. We're able to determine how many people started the IOP as well as how many people completed the IOP. And there are a couple things that we found to be very interesting in this patient flow overall. One is that our completion rate is extremely high. So on average, we know that our completion is about 91.5%. For regular evidence-based treatments in outpatient, the average completion rate is 61%. So we're topping this completion rate through our intensive outpatient program. Moreover, what we learned is that not everybody who gets accepted to our intensive outpatient program actually attends treatment. And so what we're doing at the moment is we're looking at predictors of not attending the IOP following acceptance. So we are able to use our data in a predictive way to determine who is and who is not likely to attend our IOP after getting accepted. And for those who are not likely to attend our IOP despite acceptance, we can then develop programs to help facilitate their transition into our program to make sure that they do get the care that they deserve and probably also need. When we talk about the funder level, one of the things that our data allows us to do is to generate very quick reports for all of our funders. So we pull all of the data from our post-encounter forms, our pre-intake forms, as well as the self-report assessments, and we do so in a way that can be easily submitted to our funders, and our funders can then use it to display it in the form that is shown on the very left, so where they compare different academic medical centers on the same outcomes. This then allows us to keep an eye on how we're doing, not just for the veterans that we're seeing, but also overall in comparison to other veteran organizations as well as other academic medical centers. And the nice thing is that we're able to do this in real time. So there's no delay in submitting this data. We're capable of doing this the same day. Talking a little bit more about costs. Based on the RAND Corporation data, they have shown that the estimated costs per case of untreated PTSD per 2 years is roughly $5,000 to $10,000. The cost per case of untreated depression per 2 years is higher. It's $15,000 to $25,000. And the estimated cost per case of untreated PTSD and depression is a little bit lower than just depression alone. I'm not sure why this is, but it ranges between $12,000 and $16,000. And again, these come from the RAND Corporation, and they include therapy and emergency room visit data, as well as they factor in the development of chronic health conditions when these types of mental health problems remain untreated. So when we look at cost savings, again, what we know if we take these numbers from the RAND Corporation and take into account all of the veterans who have gone through our program, is that the estimated cost for all veterans who participated in our program, if PTSD remained untreated for 2 years, would be between $1.6 and $2.9 million. When we then take a look at the estimated cost for all veterans who participated in our IOP who completed the IOP per 2 years, we come up with $675,000 to $1.1 million. So subtracting one from the other, we see that in an underestimated calculation, our cost savings for all veterans who participated in the IOP for 2 years ranges likely from $1 to $1.7 million. And it's important to note here that we are currently still in the process of actually calculating our cost savings in a very systematic way using the data we capture. So the estimates that are shown here are relatively conservative, assuming that veterans who come to our treatment do not have any other or any comorbid diagnoses or disorders, which is not the case. We know that, in fact, that most veterans who come to our treatment have a range of comorbid disorders. It's not just PTSD, but usually a combination of at least PTSD and depression, if not other things such as substance use disorders and so forth. So we hope to have additional updated cost-saving information relatively soon. So when we think about the next steps, although we've captured a lot of data and we've been able to generate a lot of insights, there are several things that we still have on our agenda. First, looking at the short term, we want to continue to refine our intensive outpatient program and evaluate the cost effectiveness like I have just mentioned. Even though our outcomes have improved steadily since we began our first cohort of the 3-week model, I don't think we're at a point yet where we can say we found the most effective combination of treatment components. And also we have not yet determined which treatment components are actually the key drivers of symptom improvement, at least not in a systematic way. So that is one of the short-term goals that we have going forward. When we look at the medium term, what we've developed here, the 3-week program, is very successful and very well liked by the veterans. I did not speak about this, but we also do collect satisfaction data, and our rankings are usually above 90 to 94% in terms of satisfaction. So our goal is to take this very effective and this very well-liked model and transport it, including the entire IT infrastructure that we have built, to other organizations so that we can overall improve the treatment of veterans across the country. Our goal is not to keep the intensive outpatient program here at Rush. In fact, we would love to disseminate this model so that more veterans and their family members can benefit from the care. And then looking at long term, what we're believing or have some preliminary evidence for is that IOP models are definitely successful, at least for a number of veterans. And so the question is this IOP format, this really short-term intensive format, worthwhile to consider as a primary treatment modality for PTSD? This is obviously an empirical question, and we will be able to answer this with the data that we capture. We're just not there yet, and this is something to explore, for which we also need additional sites information. We can't just base it off the Rush information that we currently have. So long term, this is a question we hope to answer and use the information we have to, like I said many times during this presentation, improve the care for all of the veterans to make care as effective and efficient as possible for the lowest cost needed for this care. And that concludes my presentation of the Road Home program, its outcomes, and how we use the health IT infrastructure that we've built here to really help move the program forward and offer the best possible care to our veterans that we know to date.
Okay, and we would like to thank our speaker from Rush University for joining us today and sharing their Davies story. This information, this story can be found along with other important Davies use cases, recording, and information on how to apply for Davies. All of that can be found at the HIMSS Davies Award website at hims.org/Davies. That's hims.org/Davies. Again, thank you for joining us today, and have a good day.